All right, so we're doing CHF. So we're moving on to congestive heart failure, which is a significant side effect for what? Or significant complication from what? From ACS and from a heart attack. So CHF, is it a big deal? It is a big deal. So when you get diagnosed with CHF, someone gets diagnosed with CHF, what's the chance of survival? What's their 5-year survival rate? So 5 years, like just diagnosed with CHF and you never hit the hospital setting, and the only time you hit the hospital setting, you died, you have a 40% chance of surviving, or sorry, 40% mortality. You have a 60% chance of living. So it's really almost close to a coin flip whether you're going to survive in 5 years or not if you get diagnosed today with CHF, right? So CHF today, 5-year mortality is about 40 to 40%. What if you're in the hospital? You get hospitalized once. You have a 75% chance of dying, right? That's better than, if that's all CHF, if you get hospitalized, that you have a better chance of surviving if you get diagnosed with testicular cancer. You get diagnosed with Hodgkin's and non-Hodgkin's lymphoma, you have a better chance of surviving compared to CHF, right? You have breast cancer, you got a better chance of surviving breast cancer than you do CHF. Right? What about colon cancer? And this is metastatic cancer. This is the worst kind of cancer. Cancers metastasize everywhere, to every organ known. You have a better chance of surviving that compared to CHF. Right? So CHF is significant. We just kind of, oh, they got CHF, they're fine. They got swollen legs, they're cool. Right? No, they are going to die in 5 years. What about 10 years or 15 years? 15 years, 97% chance of dying. Right? So they are not, once you get diagnosed with CHF and you then are in a hospital setting, that then escalates your chances of not recovering, unfortunately. So it's a chronic disease that we have to be considerate of, right? So diabetes, we talked about, was a really bad situation, and that led to ASCVD, which led to an MI, which can lead to CHF, right? So it's a very significant chronic disease that we have to make sure they're taking all their medications for. And there's a whole host of medications we put them on. They're called anti-failure drugs. So we're preventing their heart from getting worse and worse and worse, more and more congested, more and more dead, more and more, what's the word I'm looking for? It's more, you want to avoid them from coming back to the hospital, right? Because usually there's many different things that can trigger them to come back to the hospital. And we'll talk about that. But those things are acute exacerbation of CHF. Someone has CHF, and there can be an acute exacerbation. It can be an infection. It could be dietary indiscretion, where they took too much salt intake. It could be too much fluid intake. It could be all these things that will exacerbate their CHF. And then guess what? It's not like where they just bounce back to their CHF status before. They are permanently at the next stage, right? It's always a downhill every single time. They might recover just a tiny bit before the discharge, but it's a downward slope. And that's why a significant portion of CHF is to think about palliation or palliative care. And what is palliative care? Palliative care is where you're treating symptoms and you're alleviating suffering. So they need to know about CHF. They need to know how serious this is, and that we could do all these things right here, but if they're older, they have all these other problems along with it. They're going to be in and out of the hospital. It's going to cost millions of dollars. It's going to be a lot of pain and suffering, and we have to consider what are our goals. Do we, you're currently at this stage of CHF. This is what happens. Their survival is this, and we have to be realistic and let them know. Do you want to consider doing these other things? Because a lot of these new anti-failure drugs cost a lot of money. All these therapies cost a lot of money, and they have their own risk factors and own complications in of themselves. All right, so this is an example of CHF here. So you can see on the left there's a normal heart, and you can see the heart on the right is struggling, right? It's not able to put out a lot of blood, and that's going to decrease over time. All right, that function is going to decrease and decrease and decrease, and that's our ejection fraction. Ejection fraction is how much blood is the heart able to eject. All right, I think I put us on a permanent loop, unfortunately. Let's see what I can do about this. There we go. All right, so that's the deal with CHF as an overview. All right, so again, CHF, it's a downward spiral of heart function, right? And the CHF keeps progressing and progressing and progressing until we end up with death, unfortunately. The mortality is extremely high. So it is failure of the heart. That is congestive heart failure. And the mortality, again, we said 75% if you were hospitalized. If you got hospitalized with CHF at any one point, you are then at risk of dying 75% of the time in 5 years, right? There's a 25% survival, all right? And every hit to your heart function, it's a downward spiral. Really, this should be like a stepwise motion. And we talk about CHF exacerbation towards the end, you can see that downward spiral or that downward level of function of their heart, right? So what are the causes of congestive heart failure? You can separate into some direct damage to the heart or strain on the heart over time. So direct failure of the heart, we talked about MIs, right? So in red here, we got MIs and CAD, and that should be familiar. We talked about ASCVD being a significant risk factor. We talked about diabetes being a significant risk factor, smoking being a significant risk factor. All these things lead to an MI. Well, if you have an MI, you're at high risk of getting CHF afterwards. Just depends how big their MI is, how many vessels were affected on their MI, right? And obesity, metabolic syndrome, when we're talking metabolic syndrome, we have 3 out of 5 criteria. And if they meet those criteria, they are high risk for diabetes, high risk for ASCVD, high risk for the complications of ASCVD, which is CAD-MI, right? And that then puts you at risk for CHF, right? And if you have chronic CHF because, or chronic CHF, if you have CHF because of an MI, they technically call that ischemic heart disease. You might see that on progress notes and such. If you just have straight up ASCVD, that leads to hypertension. It didn't lead to the MI, or like directly, the ASCVD did not lead to the MI, but we took an extra step. We had ASCVD, then we developed hypertension. Now the hypertension has its own complications, one of them being MI, one of them being extra strain on the heart. So we'll talk about hypertension down here on extra strain on the heart. All right, diabetes itself, just alone, causes heart disease and CAD, but diabetes also causes hypertension, right? And then hypertension and diabetes itself are going to cause a CAD, that's where I'm at, right? This can cause CAD-MI directly. So not only does ASCVD cause an MI, so does diabetes, right? So if you have both hypertension and diabetes, that's not great. If you have hypertension, diabetes, and ASCVD, and the ASCVD was what caused the hypertension, that's 3 risk factors for a MI, and the MI causes CHF. And the hypertension is caused by diabetes, and all of that puts extra strain on the heart. All right, so all of this is leading down to one pathway, which is CHF. Smoking is inflammatory, just like obesity is inflammatory, and that's going to damage the vessels to the point where fatty streaks can develop, atheromas can develop, and now we have ASCVD and CAD-MI, right? And then cardiomyopathies. So there are some things where the cards you were dealt were not great. So you have hypertrophic obstructive cardiomyopathy, HOCM, which is just a genetic reason. So you have a genetic development of this. Usually you catch it in pediatrics. But that could be a genetic reason why your heart is failed, because it is so swollen it cannot fill with blood, right, effectively. But you can do that just on your own with excessive work, and that's with the strain on the heart. Usually with the strain on the heart, you're going to build more muscle to try to do what you can with that extra pressure it has to deal against, right, work against. But eventually it's going to give out. You don't have enough muscle, or the muscle's not going to be able to build as much as possible, and your heart's just going to fail, and it's going to become dilated. Usually hypertrophied hearts will lead to dilated hearts. Okay, so it's going to work overtime for a while, and then it's get to the point where it's just going to straight up get dilated. So here they peeled back the heart muscle. All right, this person did not survive, and they had a thin walled heart, right? That heart is extremely thin and dilated, and that heart is barely able to produce enough cardiac output, right? So that's called a dilated cardiomyopathy. That's not genetic. It is usually a just giving out. With age, your heart muscle will thin, so age more than 65 will put you at risk of dilated cardiomyopathy. And of course, we should catch that and put them on anti-failure drugs, drugs that will prevent their heart from failing at just such a fast rate. And when I talk about the statistics of 75%, that's like without any medications. So no medications, and I'll just see exactly when that was done, because we have like a couple new agents, a couple new drugs on the market that should help our CHF patients. And then restrictive cardiomyopathy. There can be genetic reasons and anti-inflammatory or anti-autoimmune reasons for it, which we're not going to get too into. But this is really where your heart is literally just hardened. It's like Medusa, right? It gets turned to stone. That's usually and like I said, an autoimmune and inflammatory reason. That's not very common, like we're going to talk about today. All right, and then cardiotoxicity. Your heart has failed because there's something in your bloodstream that's making it fail, such as alcohol. There's alcoholic cardiomyopathy. I always tell the story. We had like a 26-year-old who was in at Palmdale in the ICU, and he was a complete congestive heart failure, and from alcohol. The amount of alcohol he was drinking came to the point where it caused his heart to get dilated and dilated and dilated, and it stopped working. Right, and then his family was outside on the tailgates, having cracking down kegs. So like I think we know where the risk factors were coming from. So and that didn't faze anybody, unfortunately. So we have alcoholic cardiomyopathy. There's chemotherapy, and we talk about chemotherapy next rotation. Med-Surg 2. There's some drugs that will directly damage the heart, and now they have CHF. And then we have drug abuse. So there's meth is one of the things that cause a dilated cardiomyopathy. And then cocaine and such, and then pregnancy. That's a fetus can put extra strain on the heart. All right, and then we have we had a 21-year-old mob, and it's like, oh, how many kids do you have? 13. Oh, we know why your heart is not in the greatest shape right now. So let's put you on some medications. We might have to do some mechanical therapies to fix her heart. Okay. So strain on the heart. So extra strain, be obesity. That all the extra fat tissue puts compression on your vessels. It also is inflammatory and puts you at risk for hypertension. And hypertension puts extra strain on which side of the heart, the left ventricle or the right ventricle? The left ventricle. Left ventricle pumps blood to the whole system. If that system is hypertensive, that heart has to work extra hard. It's going to work super hard to the point where it starts getting hypertrophied. And then if your hypertension does not get under control, and what is under control? Below 130/80, then we're going to start to develop a dilated cardiomyopathy, which is obviously is worse. All right, ETOH you mentioned. ETOH itself, besides causing direct damage to the heart, causes vasoconstriction directly, and that vasoconstriction is hypertension, just with extra steps. And then ASCVD we mentioned, ETOH also leads to ASCVD, which is hypertension. And we have valve dysfunction, so they're going to put extra strain on the heart. If the heart has to pump up against a valve that is super stenosed right there, that's going to make this heart muscle work extra hard, right? Or what if this valve is leaky and we're pumping blood up into this left atrium with every beat? That left atrium is going to stretch and stretch and stretch, and that's going to then back up into the lungs, and now the right heart's like, what the heck? Where's all this extra blood coming from? So that can put strain on the heart and cause it to get dilated. All right, and smoking we mentioned can cause COPD, and we'll talk about COPD for the next exam. But COPD damages what? The P's. What's the P? The pulmonaries, right? Now that puts extra pulmonary vasoconstriction. So when you have low oxygen in your lungs, that causes the lungs to vasoconstrict. And now that's just hypertension with extra steps, right? That's called pulmonary hypertension. So COPD puts extra strain on which side of the heart? Which side of the heart pumps blood to the lungs? Nope. I think I heard LART, right? So it's the right side. The right side of the heart pumps blood to the lungs. The right side is not used to a high pressure. All of a sudden they develop this COPD over like 5-10 years. Now the heart's working extra hard. And that can cause just the right heart to fail. That's called cor pulmonale, heart failure due to the lungs. Pericarditis and myocarditis we'll talk about. That's towards the end. I think we're going to give that to you as self-study. But then endocarditis, that's also we're doing some self-study, but that's where the valve itself, that's just valvular issues with extra steps. All right, so you have your valve is deteriorating, it's getting full of bacteria, it's itising, right? It's inflamed, it's full of clots and inflammation, and that's going to cause the valve to dysfunction. And then therefore you either get stenosis or regurg, and that's going to cause the heart to fail. So what is CHF progression? You got CHF as an outpatient, they're just walking around with CHF. They're walking, and they get short of breath. Not walking, chest pain, that's called what? That's called angina, that's called CAD, right? They're definitely at risk for CHF, but if they're walking and get short of breath, that is CHF. If they got CHF at rest, right, or the CHF does not get better with rest because they're walking, they get CHF symptoms, and then they cannot recover, they now have a CHF exacerbation where they are hospitalized, a CHF with acute exacerbation. So then hopefully they bounce back from that, but again, the bounce back is very, very little. It might be like a skosh higher, but usually it's like you take 3 steps back, maybe 1 step forward. You're never going to be back at your previous EF or your previous heart function. So instead of walking, it's walking, CHF, right? So it deteriorates with every single exacerbation. And that exacerbation can be the last one, or maybe the second to last one. The second to last one being like a cardiogenic shock, where you're now in the ICU supporting your heart with a device of some sort. It can be pharmacological support. We're putting a whole bunch of squeeze in the heart to make it work harder, or we're supporting the heart very intensively. And you'll learn about this more in Med-Surg 3. We talk about the ICU management of heart failure. But you have to know here that is a possible outcome, that they could end up in what's called cardiogenic shock, where they have shock state, which is poor flow to your tissues and poor blood pressure. And the reason why was it generated? Why did that shock generate? Because of the cardio, so cardiogenic shock. And we have to do pharmacological support. We have some mechanical tricks we can do in the ICU. And once they recover, we can then transplant the heart. We can give them a brand new heart, all right? But of course, they have to meet criteria. So that pregnant lady would be a good example of someone that would tolerate this. Someone who's like 80 years old, 70 years old is not going to get a heart transplant, all right? There's heart transplant centers have their own rules about who's a candidate, who's not, okay? So you can see here we have a MI, right? That puts a bunch of dysfunction on the heart, and now the heart can't fill up with blood, or it can't pump out blood effectively. So if it can't pump blood out, where does the blood go? It stays there, or it backs up in the lungs, right? We're talking about the left heart. Left heart can't pump blood out. It's going to stay inside the left ventricle. That's going to fill up and fill up and fill up, and then now you don't get blood flow to your tissues. Your tissues get upset, right? How does the tissue get upset? Does it get the oxygen it needs? Does it get the glucose it needs? Does it get the blood flow it needs? It then produces lactic acid. And lactic acid triggers what? That's going to drop your pH, and that's going to trigger the SNS. And the SNS is going to come in and say, hey, who's not doing their job over here? And then the MI, it's like, yeah, the heart's like, I can't do my job. I don't care. It's going to increase contractility. It's increase this. It's increase the heart rate. Increasing heart rate is going to increase your O2 demand. And your heart muscle's already on the verge of infarcting. So now we're going to have more and more ischemia, right? And then more ischemia means more heart failure. More heart failure means less flow, and less flow is less blood pressure. Less blood pressure is more baroreceptor activation and more SNS. And then the kidney's like, I'm not getting my blood flow. What are the kidneys going to do? They're going to fail, and before they fail, they're going to go out with a fight. They're going to release renin, right? They're going to release renin and activate angiotensin 1 to angiotensin 2, and they're going to then go to the heart and say, hey, work harder. And then they're going to then also go to the SNS and say, hey, I'm not getting blood flow down here. Can you please make them work harder? And then they're going to vasoconstrict as well, right? SNS vasoconstricts, RAS vasoconstricts, and then we vasoconstrict, and what happens? That's extra work for the heart. And the heart's like barely trying to struggle. I can barely work. Right, and then the RAS, like, you know what would help more? My RAS has 2 A's in it, one for angiotensin 2 and one for aldosterone. Aldosterone is going to increase fluid. Oh, that's what we need just right now. It's increase extra fluid. And then guess who else is involved? Antidiuretic hormone gets involved with the RAS and the SNS. And then it's around as I'm going to help. I'm going to put more fluid into the bloodstream. So you can see how this is a downward spiral, and we want to inhibit all those things. We're going to inhibit the SNS, we're going to inhibit the RAS, and we're going to get rid of fluid. So before we talk about that stuff, let's talk some physiology. But let's take a quick break so you can get physiologied up with diuresis or fluid intake. All right, we're going to go over some physiology. And again, I'm not going to test you on physiology, but this will help you understand all the antihypertensives, all those other medications, okay? So CHF equals poor cardiac output. We got output that is poor because our heart has failed. All right, so the heart, you can measure how bad it is based on its test score. What's its test score? That is our ejection fraction, right? But what is cardiac output? It's stroke volume times heart rate. We talked a lot about heart rate for the last exam, right? The heart rate could be super fast and not fill up in time, or it can be super slow and not be, your stroke volume can be great, but if the heart rate is super, super slow, that's going to lower our cardiac output and make us become symptomatic. And what are our symptoms of poor cardiac output? That's chest pain, shortness of breath, hypotension, confusion. So those are all the side effects of poor cardiac output. So you're going to copy and paste that. Those are your side effects of CHF, but also we're going to have specific things, right? When the heart can't pump blood that way, it's going to go the other way. And what are the symptoms if it goes the other way? All right, so stroke volume, that's an important part of cardiac outputs, right? Stroke volume is how much blood ejects from the heart. And that can be three things that can make that different, right? So imagine a ketchup packet here. Ketchup packet is sealed, right? The aortic valve is closed, and we want to eject blood or ketchup from our ketchup packet, right? So how do you do that? Well, you can fill the ketchup packet with more ketchup, and it will have a better stroke volume, right? So more preload, more load of ketchup beforehand, that's going to put extra stroke volume out there. That's going to increase your cardiac output. So when we talk about shocks in Med-Surg 3, that's one of the things they say. Fill up the tank, put more fluid in. That will improve their blood pressure, right? Because blood pressure is your cardiac output's effect on the vessel walls, right? You have a great cardiac output, it's going to put more pressure on the vessels, and you get higher blood pressures, right? So blood volume is how much blood returned into that ketchup packet or returned into that left ventricle. So if no blood returns, right, you didn't put any blood in there because all of it was vasodilated out, all your veins dilated, or all your arterioles on the other side dilated, that you're not going to get blood returned to your heart, right? Your preload will be low. So when someone has extra preload because they're full of fluid, they're full of all this ketchup, and they can't eject it, then one of our strategies is to reduce the preload, right? We can say, hey, let's try to vasodilate. Let's try to get rid of fluid. How do you get rid of fluid? You diurese it. You tell the if it's going to go out to the kidneys there, say, hey, on your way there, get rid of it. I don't want you to absorb 80% of it, right? That way, when it comes circling right back around to the heart, you have less preload, and that should help a heart that's trying to struggle with what it's got, right? So heart rate, we talked about, if it's too fast, too slow, that's not going to be you're not going to be able to fill up the heart with enough blood to eject, right? And then ventricular compliance. So can the heart even allow that? If the ketchup packet's made of lead, right, it's not going to allow a lot of fluid in there, a lot of blood in there, a lot of ketchup in there. So that'd be something like restrictive cardiomyopathy or hypertrophic cardiomyopathies that could be a risk. But then afterload, so that's preload. So a lot of medications will affect preload. A lot of medications will affect afterload. Afterload is the pressure that the heart has to work against. This is the aortic valve right here, right? It's sealed right there. We need to try to get past that pressure. And what's that pressure? That's whatever on the other side. So you can imagine it like a person holding a door. It's holding the aortic valve shut, right? It's not letting blood get out, right? That's good up to a certain point, but then you eventually want to allow that to open. And what would put extra pressure on this side of the heart? What would put extra pressure right there for afterload? Is the squeeze on the vessels, right? The vessels are very, very squeezed, right? That's going to make, it's like, why would they be squeezed? Well, they have ASCVD, they have hypertension, they have cocaine use, they have methamphetamine use. All that's going to put extra vasoconstriction, right? And that vasoconstriction, now the heart has to work against that, right? The blood pressure is a measure of the pressure against the arterial walls here, right? That's all you're doing is measuring how much pressure is during systole and how much pressure is during diastole, right? So during systole, you are ejecting blood out of the heart. You are trying to contract, right? That is systole, is contraction. You're contracting and you're pumping blood out of that ketchup packet or out of that left ventricle. So all that blood is coming out, and that is, if there's a lot of pressure on the aortic valve there, that's going to make it difficult, right, for that blood to come out. If that was really well sealed, the ketchup packet, it's going to be difficult to get that blood out of the heart. So that being said, what is blood pressure? Again, is the pressure of the arterial walls during systole. So if I'm pumping all this blood from my heart into the aorta, right? So let's go here, there we go. So all that blood's pushing up against the aortic walls. That's my systolic blood pressure, right? If I have less blood coming out, my stroke volume is poor, my blood pressure is low, right? And why would my blood pressure be low? It could be because I didn't contract that well, right? Or it could be because I didn't have a chance to fill up because my heart was too fast. Or it could be due to, my preload was not great. I didn't get a lot of blood return, right? So all those things will affect my systolic blood pressure. And then the valve closes, right? For the heart to fill up in the meantime. But the blood just doesn't sit there, right? The blood is actually now squeezed through into the periphery, right? So some of it gets the periphery right there, but really 2/3 of it, of blood pressure, is during diastole, right? So all these vessel walls are elastic. With age, are they become more elastic or less elastic? Become less elastic. Become more compliant or less compliant? Become less compliant. They don't comply as well, right? So that's going to make them stiffer. So your systolic blood pressure will be higher, right? Your diastolic blood pressure will also be a little bit higher as well. So that's going to then, it's like a trampoline. It's going to stretch, and then it's going to bounce and then squeeze out into the periphery. What if your periphery is super tight? It's vasoconstricted. That's going to raise the diastolic blood pressure, right? That raises afterload, because now the heart has to work against that. To open that door again, it has to work and try to, oh, why is it so difficult? It's because they were squeezing out there. So how do we fix that? We vasodilate out there. That's going to decrease what? Primarily it's going to decrease afterload, right? It's going to open up those vessels, allow the diastolic blood pressure to go out of the periphery easily, and that's going to make it easier for the next go around. Okay, so that's the idea behind our medications. They're going to affect afterload or preload. And what's the whole reason of having like a temporary storage of blood is this is an example of without that piece, right? So the heart contracts, and then you can see how it's squeezing down. It's a way so you have constant blood supply to the whole body. That's the whole point of this process, right? The arteries stretch and allow that to happen. What if you didn't? What if you had no arterial stretch? Systole, done. Systole, done. Systole, done. So diastolic blood pressure is an example of a way to get your body perfused at all times, right? And you can raise the diastolic blood pressure by making it more difficult to squeeze out that hose. You make that hose tighter. The next go around, that systole has to work extra hard to get that fluid out, right? So there's another example of congestive heart failure, or it's just normal anatomy. So your heart is squeezing and it's pumping that stroke volume with every beat. And how much is it per minute? Well, how many beats per minute is it? Well, that's my heart rate. Heart rate times stroke volume is our cardiac output, right? And normal stroke volume is about 70 cc, 70 mLs of blood, okay? And that can then, why is it 70 cc's? My ketchup pack is 100 cc's, and I hit it, and then 70 cc's comes out. That's great. That's a good test score, because the possible test score was 100, but 30 ml was left behind, right? So what's my test score? It's how much came out versus how much came behind, how many I missed. That's my test score, 70%, right? So it can be lower. What if I can't hit the ketchup packet that hard enough? I only gave 50% out. 50 left with stroke volume, and 50 was left over. That's my end diastolic volume. So that was the amount of blood left at the end of, end of systolic volume. So end diastolic minus end systolic volume is our stroke volume, and that can be affected with someone with heart failure. All right, so that's the idea with cardiac output, and we have to illustrate it to you so that you can understand how all the medications are going to interact. All right, so this is like a recap on paper what we talked about on the downward spiral. On the first slide, we talked about MIs, but let's just talk about CHF in general. The heart's not working for any reason, right? The heart's ejection fraction is poor, right? Our goal with heart failure is to improve cardiac output as much as possible. And how do we do that? We can, the heart is unable to pump blood because there's too much blood to work with, right? And the afterload is way too high. The tissues are not getting the blood flow they need, so what do? They trigger the SNS, they trigger the RAS, they trigger all these neurohormonal things to cause the heart to work harder. Right? They think they're helping, and they would help if we didn't have CHF, right? Normally, you would say, oh, I want to increase the blood pressure, go and squeeze down, that's going to increase my blood pressure. Go ahead and retain some fluid, that'll increase my blood pressure. But in CHF, we got to stop that, right? Also, it's not just like a temporary thing. They're going to be doing it for 30 days, 60 days, 90 days, a year, 2 years, 5 years, 10 years, and then they're going to present to the hospital with congestive heart failure, with dilated cardiomyopathy, because the heart was being bullied by all these hormones, right? And all these hormones like, move aside, I know how to make heart muscle, and they don't. And the heart muscle is actually worse than it was before. It's like, why are you failing? It's all you. It's like, no, you're the one that gave me these tools. You kind of set me up for failure. So that's called ventricular remodeling. So we want to stop that as much as possible. So when we talk about medications, you want to try the medication, you want them to be on the medications that are going to stop ventricular remodeling. So potential question would be like, my blood pressure is 101 systolic. I only want to take one BP med. Which BP med should it be? It should be the one that stops ventricular remodeling versus the one that just makes them diurese, right? So ventricular remodeling is the most important piece behind CHF. You want to stop that from happening. You want to stop this neurohormonal cascade. So heart's barely able to pump right there. And then what happens? The SNS triggers because the blood pressure is low in the aorta, and blood pressure is also low in the kidneys, but now the SNS fires off. And then now the kidneys don't get their blood flow. And they are like, what the heck, where's our blood flow at? And they're going to do their thing. And their thing is what? Is the renin-angiotensin-aldosterone system. All right, so we're going to recap what these are. And if you know it by like back of your hand, I apologize. But you need to know how these work because you're going to be able to get to the right answer every time. Oh, that one causes hyperkalemia. Oh, that one causes hypokalemia. That one's going to cause this to happen. You'll get that when you know how it works normally. So again, the SNS, the tissues don't have oxygen. Lactic acid gets formed, low oxygen. Both those things are stimulus for the SNS, right? So that's a downward spiral. You get poor output, and the SNS fires, and then you don't get poor output still because the heart has failed for some reason or another. All right, and then that's going to try to increase heart rate, increase contractility, but that's more O2 demand. That's more stress on the heart. And it says, move aside. I'm going to make you even stronger, right? It's like temporary steroids. Ever seen someone that's like 65 years old who's been using steroids all their life? That's like heart failure. All right, so they're not going to be the best. They're not going to look like what a heart should look like, right? So that's going to increase afterload, increase the work the heart has to do, and therefore the heart's going to try to do its best, but it's going to eventually fail. But before that, the SNS also triggers the RAS directly. Not only does the SNS trigger it, but just low flow to the kidneys is what triggers it. Low flow to the kidneys, low blood pressure or low sodium flow to the kidneys, that is going to trigger the RAS to fire off. And the RAS has two A's in it, one for angiotensin 2 and one for aldosterone. All right, so angiotensin 2 is usually our like meat and potatoes of the RAS system. That's going to vasoconstrict everything. And if you vasoconstrict everything, what's that going to do to the heart? It's going to put extra stress in the heart because it's increasing what? It's increasing blood pressure, specifically diastolic blood pressure, which is the afterload. So the afterload gets increased. That's great when you're hemorrhaging on the street. That's not great when you have CHF over 5 years, right? And that's going to increase myocardial workload, and it's also going to remodel the heart. It's like you get two bidders to make your cabinets, and both of them don't know how to make cabinets, right? It's the first time making cabinets. And then aldosterone is the second A of this system, and the second A is our aldosterone, which does what? How does that help our blood pressure? It's going to go to the kidneys and tell the kidneys reabsorb more sodium and water in exchange for potassium, right? So where sodium goes, water goes, and that's going to do what? So it's going to increase our preload, right? It's going to increase the volume. Is that going to help a heart that's congested? No, so that's not good. So we got to stop the RAS, we got to stop the SNS. And then the cherry on top is ADH. ADH is also witness protection. It has like 6 different names. It has vasopressin, ADH, L-arginine vasopressin. It has AVP. It has so many different names, but it vasopresses. So that means it's going to press the vasos. It's going to cause a rise in what? Blood pressure. It's going to vasoconstrict, right? It also does another thing, which is tells the kidneys hold on to water. It's an anti-diuretic hormone. It stops you from diuresing. And is that going to help CHF? No. But if we stop the SNS, we stop the RAS, you're going to stop the stimulus for ADH. And then we have the good guys. So these are the things we want to have around. These are the guys AMP and BMP. So atrial natriuretic peptide and brain natriuretic peptide. And again, no one says, but it doesn't come from the ventricle. Shh, don't say anything. All right. So they said, but it comes to the ventricles, right? Shh. But they don't want to admit they're wrong. So it does come from the ventricles. It does not come from the brain. It was discovered that, maybe it comes from the brain. They wrote a paper on it. It does not come from the brain. It comes from the ventricles. So the atrial natriuretic peptide comes from the atria, and nobody wants to change it. So AMP and BNP, these are great. What does natriuretic mean? Uretic's the natriuretic, right? So it's going to make you urese. It's going to make you pee out Na. What is Na? Sodium. So you pee out sodium. So AMP and BNP are going to natriurese. It's going to make the sodium go in the urine, and your water is going to follow. And that does what to our preload? It's going to decrease it. That's great, right? But what happens is that we have that AMP BNP gets released, and it gets broken down immediately. So why don't we stop the breakdown of it? So what breaks it down is naproxen. So naproxen right here breaks down AMP, BMP, and that's going to be bad news. We don't want that to happen. So we have one drug on the market that stops naproxen, okay? And therefore we get more AMP and BMP circulating, and that's going to help us out. Right? It's going to help someone with congestive heart failure. And the other benefit of AMP, BMP is it shuts down the RAS. That's great, because RAS is part of the problem here. That's part of the issue, okay? So again, the RAS system. You got renin that converts angiotensin 1 to angiotensin 2, and we have what? We have ACE inhibitors out there. That's going to stop that. And then we also have angiotensin receptor blockers. That's going to stop the effects of angiotensin 2. And that's great because that's going to help the heart out, right? Because what does angiotensin 2 do? It increases afterload, right? It also goes to aldosterone and says, hey, what are you doing? Let's go out. And they go out and they're going to raise the preload, and that's not good, right? So it's going to stop, and it also goes to the brain and says, hey, what are you doing? Let's go out. And it gets ADH involved, right? So we're going to stop all of those things from happening. Right? And then the SNS, by the same token, the SNS gets fired up, and it's going to go ahead and say, I'm going to try to make the heart rate beat faster, and we're going to make it contract harder. And also, we're going to tell it how to do its job, how to make ventricular muscle. So we want to stop ventricular remodeling. The RAS and the SNS say, I know what cake looks like, and that's not what a cake looks like. Right? I know what this looks like, that is not what it looks like, and that is non-functional. Right? And over time, it is going to be, going over time, and then that CHF is going to get worse and worse and worse over time. Okay, so this is how it works normally, right? So I know you're feeling like this right now, but that is how you're going to understand the medications. That's how you understand all the different symptoms and why we do what we do. So the symptoms. So if you can't pump the blood forward because it's trying to make it work harder, it's not going to be able to output that blood effectively, right? And traditionally, it's separated into left and right heart failure. And we have different names for it, of course, now. But if your left heart isn't working, what does your left heart pump to? It pumps to the brain, pumps to the kidneys, it pumps everywhere, right? It pumps to your system. So if you can't pump the blood out, then we have all those hormones that are kick in. But if you can't pump the blood forward and all that other stuff happens, the blood's going to start backing up, right? It's going to back up where? In the lungs, right? So you back up in the lungs, and now your lungs fill up with fluid, and you can auscultate that. And what does that sound like? It sounds like crackles. And you got rails and auscultation, or crackles, and then they'll have like a chronic cough, and then when they're really, really in trouble, when they're really filling up with fluid, you can hear the crackles all the way at the apices, and also they might sound wheezy, and they're going to start coughing up phlegm, and this phlegm is going to be pink and frothy. So pink frothy sputum is like pathognomonic for CHF. What does pathognomonic mean? Textbook means if you have that symptom, you have that disease. There's like no other reason for that symptom. Pink frothy sputum, 100% is CHF, right? So you see pink frothy sputum on the exam, like, oh, you're not gonna look at anything else. Where's CHF at? There it is. Okay, move on. Right? That's it. That's pink frothy sputum. Bam, you have it. Crackles could be a few different things, but if they have CHF, that kind of explains the crackles. So all this fluid getting into the lungs and filling up the tank there is called pulmonary edema. So pulmonary, if you have all that fluid in the lungs, or do you think you might be hypoxic? Yes. So you have all the symptoms of hypoxia. What are symptoms of hypoxia? SNS firing off, and they got late cyanosis. They got what else? They got restlessness, right? They got a low O2 sat, a low PO2. All these things are hypoxia. So pulmonary edema is just hypoxia plus crackles / pink frothy sputum. That's it. That's pulmonary edema. All right. It can be caused by CHF most commonly. There's a few other things. You talk about Med-Surg 3, but pulmonary edema is classic for CHF because the left heart is not pumping the blood forward. Okay. They got dyspnea on exertion. Well, that makes sense. So the heart's being extra stressed out as going forward, going 10 feet, 100 feet, 1,000 feet, and then it's like they got to stop because they have dyspnea on exertion. They're walking, and they get shortness of breath because all that walking is triggering the SNS, and the SNS is making the heart contract harder and harder and faster and faster. That's going to make them be symptomatic, right? So that's also, if that does not resolve, that's called CHF exacerbation, especially if it's at rest, right? They have that dry hacking cough at all times. It might not be like the fluid not fill up all the way to the apices, but if that fluid is causing irritation of the bronchioles and irritation of alveoli, and they're going to cough a lot. So the dry hacking cough is classic for a CHF patient. And again, if it gets to the point of low cardiac output, then we got chest pain, shortness of breath, which is there. Hypotension, that's really bad for someone with the heart's not able to pump blood out effectively. And then confusion. Confusion is usually a late sign. Usually when someone's confused with CHF, they might have some other things going on, but if it's the CHF itself causing the confusion, that's a really, really advanced CHF, and they probably are on the verge of cardiogenic shock, which is the worst case scenario. All right, PND, paroxysmal nocturnal dyspnea. That is classic for a CHF patient. They get short of breath in the middle of the night, 2 to 4 a.m. They get classically short of breath, and if they have that during the night, and it's constantly happening, that's a reason to call 911. So one of our last slides we'll go over is reasons to call 911. One of those reasons is they're short of breath at rest, of course, right? Or they're short of breath increasingly, right? I used to be able to go to the mailbox and back, or take the trash out and back. Trash out tomorrow, right? Okay, so the trash out and back, and then that's going to be a bad thing. That's a bad CHF. And they have to seek out help if that's getting worse and worse. And they have to seek out help if they can't sleep at night because they're short of breath. That's also a reason. Or they got pink frothy sputum, you gotta go you go straight to jail, straight to the hospital, I mean. All right, so you gotta go, and then other things, S3 and S4, we'll talk about this more with valves. All right, when we study valves, we'll study the reason why S3 and S4 happen. All right, but that's left heart failure. What about right heart failure? The most common cause of right heart failure is left heart failing. Because left heart fails, all that blood backs up in the lungs. The right heart is like, what'd you do to me, man? Well, now I got to work against all this blood flow, right? So now the right heart has to work all against all this flow here, right? So here's the lungs right here. The right heart's trying to pump blood to those lungs that are full of fluid, right? And now it's like that's extra work for the right heart. It's not used to that. So because it's not used to it, it can fail, right? It can't pump the blood effectively to the lungs because there's fluid in the lungs, so the left heart wasn't doing its job, and now it's backing up into what fed it and what feeds the right heart. The veins, right? All the veins, the systemic veins, all feed into the right atrium. So if we're having right heart failure, everything the veins came from is get full. All right, so if we go north to the right atrium is backed up, right? There's a line now. It's backing up into the neck, and what's that called? As JVD, jugular venous distension. Our veins and our jugulars are distended. We have JVD, right? And then what's next? Let's go south now. What's the next step after our right atrium? If you're vena cava, then it's all anatomy, right? What's next? The hepatic vein, which then leads into the right. This all remember your anatomy, drawing the veins out, right? So hepatic vein feeds into the liver. So my liver gets congested, right? And now I got hepatomegaly. I got a megalic hepato. What does megalic mean? Means big. I got a mega hepato, right? So I get a swollen liver, and my liver is going to get congested. I can get actually cirrhosis from that. Then we'll talk about cirrhosis next semester, but that liver can stop working, and then now you got all kinds of problems. You got 500 problems, right? And then you can also back up into, what's the next vein? Superior mesenteric vein, right? All right, so the next vein is going to be your gastric, bowels, colon, all those things are going to get full of fluid, full of all this extra congestion, right? So including the spleen. So you get splenomegaly. So you get hepatomegaly, splenomegaly, and you get all this fluid into your stomach and into your intestines, and those intestines are going to work good now. Just like the alveoli get full of fluid, O2 can't transport, now food can't transport. And now they don't want to eat. All right, they get anorexic, not like anorexic nervosa where they lose weight. That's a psych disorder. Anorexia just means I'm not hungry, right? Why aren't you hungry? Because all this fluid's in my gut, and I don't. When I take food, it doesn't feel good. Okay, and all that fluid can back up into the interstitial spaces of the belly and cause ascites, which is fluid buildup in the belly. And then what's next? Let's keep going south. You got the kidneys. The kidneys, don't get blood flow from this side, right? From the heart not pumping blood to the kidneys themselves, right? That can cause the kidneys to fail. But also all this fluid backing up. Even if you did pump blood to the kidneys says, okay, I'm done with this blood now. Let's go back to the veins. They're all backed up now, So the kidneys can fail. And that's an important cause, important complication of CHF is kidney failure. And the kidneys fail, and now you can't get rid of fluid. And now you have increased what? Increased preload. And that's not what we want for CHF. All right, and then, so we got JVD, hepatosplenomegaly, we got mesenteric filling, and then what's left? It's all that fluid is going to be a lot of weight on the veins, and the veins can only hold so much until they separate out and they start getting leaky, and they start leaking out fluid into the peripheral tissues, right? And that's called edema, right? Peripheral edema. And it's usually dependent because those areas are going to have a lot more gravity on them, right? All that fluid's going to fill up, and you get some feet that are what? Very swollen. So you have feet that you can play with, and you can see that they got dependent pitting edema, right? So it stays there. If the amount of time it stays there doesn't matter, it's the depth that matters, whether it has 1, 2, 3, or 4 millimeters, right? So that's a dependent edema that occurs. Okay, so you can memorize, have whatever kind of mnemonic you want for these symptoms, or you can kind of walk through it. Oh, JVD, next I got liver, got spleen, I got gut, I'm going down kidneys, and I got my feet, right? So that's the idea behind giving you the why behind all these things. And he's like, oh, this guy's talking about all the physiology, what the heck? You're like, why do I have to know my anatomy and mesenteric veins? Well, it kind of makes sense how it's sequential it is. Okay, so that's our deal here. The other deal that can happen is, what if our left heart is the most common cause of right heart failure, but what if when we talk about COPD, COPD causes hypoxic vasoconstriction, causes all of our vessels in our lungs to constrict, right? So when that happens, that's going to be extra work for who? The heart that has to pump blood to the lungs, which is which heart? Right heart, right? So the right heart is like, what the heck? Why is this so vasoconstricted? And that's going to put extra strain on the right heart, and just the right heart will fail. If just the right heart fails, that's called cor pulmonale. Okay, so cor pulmonale has all the same symptoms, right, of right heart failure, but they don't have left and right heart failure. They just have just the right hearts failing, like with COPD, for instance.